definitely live, you're sure?
Yep. Look here. Look at
All right, good evening, ladies and gentlemen. Welcome tonight to the Ultimate Pulmonary Wellness Webinar Series, June edition. This is going to probably be the last webinar of the season before we take a little summer break and kick back up in September again. Tonight I have quite a bit of information that I want to share with you. But I want to make it relatively simple. I want to give you some really important information and teach you a lesson, not about specific medicine or specific things about pulmonary disease, but I want to teach you how to think about things so that you will be able to learn more continuously on an ongoing basis. So this is the teach a man to fish, if you will. So before we go on, I want to say hello to all the members of my group, the Ultimate Pulmonary Wellness Facebook group, and I would like to invite anyone who is not a member of the group to join the group. And without further ado, let's begin. If you have questions, by all means, feel free to type them in, and I will try to get to them by the end of the show. Now, I want to talk about some questions that I heard this week, and some of them I'm going to talk specifically and give an answer to the question. Others I'm going to bring it into a general format about how you should think about different signs and symptoms that you become aware of. So here is one question, and this question came to me online, and this question says, I keep using my shoulders as earrings and it hurts. I raise my shoulders to breathe better without thinking. I have no idea how to stop doing this. Just know that my shoulders ache most of the time. So this is a question that deals with a very, very common concept that we've spoken about many times before, but I'll talk about it again. So when we talk about breathing, I talk all the time about how breathing is a multifactorial process, and there are many, many factors that go into how well or how poorly we breathe. The main muscle of inspiration is the diaphragm, okay? And the diaphragm basically is a dome-shaped, very thick muscle that sits here in between the abdominal cavity and in between the thoracic cavity. And what happens is when the diaphragm contracts, the diaphragm contracts downward, and that creates a negative pressure, and it's that negative pressure that causes the lungs to inflate. Now, when people have a respiratory disorder, and it almost doesn't matter what the disorder is, and I'm addressing people now with obstructive diseases, particularly people with emphysema and hyperinflation of the lungs. This is something that we hear a lot. People with obstructive diseases have difficulty blowing air out, and as a result, we wind up with hyperinflated lungs, okay? These hyperinflated lungs push down on the diaphragm that is supposed to be dome-shaped, and it puts the diaphragm at a relatively poor mechanical advantage. Other things like restrictive lung disease, in this situation you have difficulty breathing air in, and as a result you wind up with smaller lungs, and the diaphragm can actually be higher in position. So like most muscles, okay, there is going to be an optimal position at which that muscle likes to contract, and it's usually somewhere in the middle of the range. What do I mean by this? Let's use the bicep as an example. If my arm is stretched all the way out so that my bicep is lengthened to its maximal length, that's not the best position to generate bicep strength. Likewise, or conversely, if my arm is all the way bent so that the bicep is totally contracted, that's also not a great position to generate bicep strength. The general best position for most muscles is going to be somewhere in the mid-range, and that goes the same for the diaphragm as well. So the diaphragm doesn't like to be too high, it doesn't like to be too low. When people have difficulty breathing, and when they have a diaphragm that is not operating at its most optimal, they use what we call accessory muscles of respiration. And these accessory muscles include the muscles of the neck, the muscles of the chest, the muscles of the back, the muscles of the thorax, including the serratus, the muscles in between the ribs, the intercostals. And what we wind up seeing a lot of times is we see people who are breathing, and as this question implies, I keep using my shoulders as earrings, okay? They're using the traps, they're using the muscles of the neck to elevate the rib cage and help take a breath. Now, this is not a very efficient way of breathing, but in addition, these muscles were not meant to do these things. And as a result, these muscles get overworked, they get tight, they go into spasm, and when a muscle goes into spasm, they wind up with even more pain, because the way that a muscle gets nutrition is by contracting and relaxing. So when it relaxes, blood flows into the muscle. When it contracts, blood flows out of the muscle, removing waste products. Then it relaxes again, and fresh blood comes in with nutrition. So the idea of this question is, I keep using my shoulders as earrings and it hurts. We have to break into that pain spasm cycle in some way, and the way to do it is by either releasing the spasm or taking care of the pain, ideally doing both. But it also involves learning to breathe most effectively, and that involves things like diaphragmatic breathing, learning to use the diaphragm and retrain the diaphragm again, pursed lip breathing, slowing breathing, controlled breathing techniques, and paced breathing during activity. All of these techniques are covered, I believe, in webinar 3, Your Best Breathing Techniques Ever. So I'm not going to bore you with them tonight, even though they're not boring. They're very interesting, but they're all right there for you. Like I said, I believe in webinar 3. So you have to stop doing this, okay? You have to learn to relax the shoulders. You have to learn to breathe more effectively with the diaphragm. And in the meantime, you can treat that shoulder pain. You could treat it with heat. You can treat it with ice and cold. You can treat it with stretching. You can treat it with acupuncture. You can treat it with physical therapy. But we have to break into that pain spasm cycle. Okay, let's go to another question. This question here is, and this is related to what I just said. This says, I have COPD emphysema stage 4, severe emphysema. Why has my chest gotten so large? And this has to do with what I was just talking about, which is the fact that obstructive diseases cause you to trap air. We wind up with what we call an increased residual volume, and there's a residual volume in the lungs that even if we blow all of the air out of our lungs, the lungs never have zero air in them. There's always a residual volume. And when you have emphysema, as that emphysema worsens, many people become hyperinflated, as I mentioned before. That residual volume increases, and as a result, our chest becomes more expanded. It's what we call a barrel chest, and what we're talking about is an increased AP diameter, it's called, or an increased anterior posterior front to back diameter. So if you look at somebody with severe emphysema from the side, they are going to have a wider than normal chest. Okay, so that answers that question. Next question I want to talk about. This is from Gene. Even though you can definitely improve shortness of breath with medication, rehab, pursed lip breathing, etc., why is it so hard to carry a bag of groceries or pull a small suitcase even on wheels? Is it the exertion? Okay, good question. And again, the answer is maybe, okay? Again, breathing is multifactorial, okay? So the question is, why is it so hard to carry groceries? That depends. Are you carrying them across your chest? So we want our chest to be open and free to expand and contract, okay? The more we raise our arms, okay, the more we extend our arms, the greater ability we have to elevate the rib cage to take a deep breath. If you're carrying a bag of groceries here, we're clamping down that rib cage and mechanically restricting a deep breath, making you more short of breath, having to work hard with each breath that you take in order to meet the demands of that increased carrying of the bag. Now, if you're carrying the bag one bag on each side, okay, think of what's happening here. This is a weight that's pulling down on the rib cage, and again, now it's divided in two. However, there's now a mechanical pulling in a downward direction that is not allowing. So imagine if I gave you two weights and you had to elevate your rib cage, or those weights were hanging off your rib cage by holding them in your arms. We have a very similar restriction to you taking a deep breath. Same thing with pulling, okay? When you're pulling something or you're pulling something behind you, that is increasing the resistance against which your respiratory muscles have to breathe in. Now here's something that's a little bit different, okay? People talk about groceries. When you're pushing something, okay, or when you're leaning on something. So as in the case of a shopping cart or a grocery wagon, okay, if you're actually leaning on it, that gives you an added advantage. And this is something that is correct also as far as when you're on the treadmill. Normally, okay, the muscles of the chest, back, thorax, shoulders, okay, when we use the chest muscles and the back muscles, they usually do things like this if our arms are open. So the chest usually does things like this. The shoulders can do things like this. The back muscles can do things like this. But this is what I refer to as open chain activity. Open because this chain is open here. When you lean on something, whether it be a treadmill, whether it be a desk, whether it be a shopping cart or anything like that, when you put your hands down or when you fix your upper extremities on that device, we are doing what I call closing the chain. And when you have a closed chain as it relates to the respiratory muscles, the muscles that I just talked about, the back muscles, the thorax muscles, the shoulders, the chest, all of those muscles work in their reverse action to help elevate the rib cage and allow you to take a deeper breath. And we learned this a long time ago by watching patients, because patients who were short of breath would come in and they would sit in a position like this with their elbows fixed, or they'd be leaning forward on their elbows in their chair, or they'd be leaning against a desk in order to instinctively help them to breathe. All right, other questions as we move along. Dear Noah, can moderately severe emphysema cause fatigue? What should I do? Can it cause huge appetite or hunger? Can it cause belly bloating, wind or gas? Okay, good questions, okay? And the answer to these questions are yes, it can, but it may not, okay? And one thing that I want to talk about tonight is a concept that I call the Facebook diagnosis, or Dr. Google, or the internet diagnostician, okay? A lot of times, and understand that what I'm about to say is not a criticism, it's not a blame of anybody for doing anything, but a lot of times what I'll see is I'll see on the different boards, people will ask a question, or people will say, I'm experiencing this symptom, is this normal? Okay, so someone will say, I'm experiencing chest pain, is this normal with COPD? Or they'll say, I'm having difficulty breathing. And I think the fact is that for most people, when you ask a question, what you're looking for is you're looking for some kind of reassurance. You're looking for somebody to say, yes, that's normal, or no, it's not normal. And I think that in itself is normal, okay? But I want to talk tonight a little bit about the diagnostic process and what we call differential diagnosis. And I want to talk a little bit about my thought process, both as a cardiovascular and pulmonary physical therapist, and also as an EMT, what goes through my mind when people come to me and say, this is what I'm experiencing, as far as, is this an emergency? Is this something normal? Or even if it's not normal, is it understandable under the circumstances? Or what should we be doing about this? So here's the first question. Can moderately severe emphysema cause fatigue? Anytime you have a difficulty breathing, any respiratory issue, anything like that, of course it can make you more tired. Why? Because even sitting here doing nothing, you are working harder just to breathe. So I may be sitting here thinking that I want to rest, but if I have severe emphysema and I have to expend twice as much energy to take a breath that I would if I didn't have emphysema, naturally it's like I'm working out even when I'm sitting and doing nothing, and that can be extremely fatiguing, okay? What do we do about it? You can learn more effective breathing techniques, things like pursed lip breathing, diaphragmatic breathing, learn to use paced breathing during activity, and then use these breathing techniques during exercise in order to make your body more efficient, okay? Can it cause a huge appetite and hunger? It can, okay? Again, you're working harder, okay? You're burning more calories even when you're doing nothing, but also I would want to know things like what medications are you taking, because there are a lot of medications that can increase your appetite that can also decrease your appetite. And can it cause belly bloating, wind and gas? And the answer to that also is yes, because it's very possible that you're swallowing air, or that when you're trying to work hard to take a deep breath, that air is actually going into your esophagus when it really should be moving in and out of your trachea. All right, here's a couple of other questions that are going to launch me into my talk about different signs and symptoms. So here's number one. I need some input. This came from the Ultimate Pulmonary Wellness Facebook group. I need some input. I am having pain under my left breast, in my rib cage, and around the back a short ways. Can this be lung related or something else? Okay, and then after that there's a whole bunch of responses from other members of the group in which they're saying, this is what I think it is, or it's probably this, and it could be anything from muscle spasm to could be your heart to pleurisy to a whole bunch of other different things, okay? So before I even answer the question, I'm going to tell you this. I'm going to say that my answer was, somebody said if that's new, check with your doctor to make sure it's your heart. And the person who asked the original question said, no, it's not my heart. I've had it before when I had really bad gas. I also carry my O2 tanks on that side of my body. My question to that person, or my comment, was, how do you know that it's not your heart? I'm not saying that it is your heart. I'm just curious what testing you've had done. You write that you've had this feeling when you had really bad gas and that you carry your oxygen on that side of your body. While I don't question these factors, they do not on their own merit rule out the heart. So one thing that I want to talk about when it comes to symptoms, okay, is that we can't tell from Facebook, from a question like this, what is wrong with you. So the question is, could it be the lung? Yes. Could it be the heart? Yes. Could it be muscle spasm, as somebody else suggested? Yes. Could it be indigestion? Yes. Could it be something else? Yes. Okay. But you have to understand, a lot of times somebody will say, oh, I know what that is because I had that, and it's this, and this is what I did for it, and that's what you should do for it, okay? But what I'm trying to get at is the fact that there's a much more scientific way of sort of figuring things out, and not just figuring out what it is, but the best ways of figuring out what it is by figuring out what it isn't, okay? And that is what's known as differential diagnosis. Now, if you have a pen and paper, I would like you to write down the following things, okay? It's very short. Write down what I'm about to say, because I want you to keep this as a reference for signs and symptoms in the future, really symptoms, okay? Write down O, P, Q, R, S, T, I. O, P, Q, R, S, T, I. If you have trouble remembering that, O, P, Q, R, S, T, and then after T you say, oh, I. O, P, Q, R, S, T, I. So these are the things that I think about when somebody comes to me and says, I'm having this pain, I'm having this sensation, I'm having this is what I'm experiencing, what do you think this is? And what I'm doing with this is I'm trying to create a framework that will help me figure out what it's ruling out, what it's ruling in. O stands for onset, okay? So if you come to me, I'm gonna use chest pain as an example. So somebody comes to my practice and they say, I had some chest pain yesterday, or I'm having chest pain today. I wanna know about the onset of the chest pain. So when did this happen? What were you doing when this happened? So the person will say, I was on my way to the center today and I was walking up the subway stairs and it was so hot and humid that when I got to the middle of the second flight of stairs, boom, there it was sitting in my chest. So that's telling me about the onset, okay? P stands for provocation and palliation. Provoke and palliate, okay? So what that means is what makes it better and what makes it worse. So palliation is what makes it better, provocation is what makes it worse. So there are times when somebody is going to say, okay, when I walk up a hill, this makes me short of breath. Or when I walk up a hill, I get chest pain. Or when I walk up more than 2 flights of stairs, I get a pressure in my chest. So we talked about O, onset, P, provocation, and palliation. And then I say, okay, so you get to the top of the 2nd flight of stairs and you're now having chest pain. What do you do? Well, I stand there for a little while and I do my deep breathing techniques and it usually subsides. That's my palliation. So provocation is I was walking up the stairs. Palliation is I stand, I do my breathing techniques, I rest, and it goes away. Q stands for quality, and particularly when it comes to the thorax, okay, quality of discomfort is very important. I say often that between the neck and the belt, we have many, many systems, but most prevalently, we have the cardiovascular system, the heart, we have the respiratory system, the lungs, and we have the GI system, okay? And the reason why it's really important to understand these 3 systems, particularly as a professional and particularly as somebody who takes care of cardiopulmonary patients, is because very often the symptoms of the heart and the cardiovascular system can be very similar to the symptoms of the respiratory system in the lungs, and those can be very similar to the GI system, the gastrointestinal system, and the stomach, okay? And I want to make sure that I am not going to dismiss something as gas when somebody is really having a heart attack. And knowing these things and knowing the different characteristics of each will help you to figure out what is what. So now we're up to quality. Quality means, is it sharp or dull? Is it pressing? Is it squeezing? Is it burning? Okay? A lot of times someone will say something like, I'm having chest pain. Now, can respiratory disease cause discomfort in the chest? Absolutely. Can cardiac disease or cardiovascular disease cause discomfort in the chest? Absolutely. Can the GI system cause discomfort in the chest? Absolutely. Okay. And again, I want to make sure that I'm not going to dismiss something serious as something not serious. And when in doubt, I will always, always, always err on the side of caution. Okay, I'm not going to say, well, you know what, let me roll the dice and see if it is your heart. Okay, and when I say the heart, okay, the heart is the one that I'm most worried about. Okay, I don't think there's too many people that have died of gas or acid reflux. Not that it's impossible, but the thing that I worry about when somebody reports discomfort somewhere in the thorax is I worry about the cardiovascular system. So when we talk about the heart, very often, okay, somebody will say a squeezing feeling. When someone makes this fist and clenches it across the left side of their chest, that's a pretty good indicator that we're looking at something cardiac in nature, okay? If it's in the center of the chest, it could be the heart, or it could be the lungs, or it could be acid coming up from the GI system, okay? When we talk about angina, okay, or this discomfort that comes as a result of the heart not getting enough blood flow, okay, that, you know, what we classically think of as angina is we think of substernal chest pain, left-sided substernal chest pain that radiates down the left arm. However, many people do not experience angina in the exact same way, and so we often look for things that we call anginal equivalent. So it may not be this left-sided squeezing that goes down the left, you know, the left arm. It may be something like a discomfort in the neck. And the reason why that gets tricky is because acid reflux can also cause a discomfort in the neck. A lot of people with heart disease will report some type of jaw discomfort or like a clenching of the jaw. A lot of people with heart disease may report pain in the shoulder blades or in between the shoulder blades. And that's why when somebody asks me a question like, I'm having pain under my left breast, right? Think about where this is, in my rib cage and around the back a short ways. Can it be lung related? Absolutely. But can this be the heart? Absolutely. And for me, I don't want to take a chance and guess at what something is until I have evidence of what it was. Now, it just so happens that I spoke to this person after they went to the doctor today, and it wasn't their heart and it wasn't their lungs, it was shingles, okay? Which is something that we never probably would have thought of. However, again, I'm always going to err on the side of caution, particularly when something is new onset. Okay, so we talked about onset, we talked about palliation and provocation, what makes it better or worse. We talked about the quality of the pain, is it sharp or dull? And incidentally, a lot of times when somebody's having chest pain and you say to them, is it sharp or dull? And they say, it's sharp, it's sharp, it's sharp. They're scared because it's sharp and they think that sharp is automatically worse. Well, no, sharp is not worse when it comes to the heart, because the heart usually doesn't give us a sharp pain. The heart will usually give us a dull pain, a squeezing pain, a pressure, and so if somebody points to me and they say, I'm having a sharp pain right here, I'm guessing it's probably not the heart. It may be, something related to the lungs. It may be something musculoskeletal. But again, when in doubt, assume it is the heart. Get it treated right away, or get it looked at right away, because when it comes to the heart, we say that time is muscle. So if something is going wrong with your heart, then the first hour, we call it the golden hour, is crucial, okay? So now I want to talk about R. R stands for radiation, okay? So radiation means, does the pain go anyplace else? So you have this substernal pain. Does it radiate down your left arm? Does it shoot across the neck and go around to the back? Does it go up to the jaw? This is radiation, okay? S stands for severity. On a scale of 1 to 10, 10 being the worst pain you've ever felt, 1 being minimal pain, and 0 being no pain, okay? How bad is this? And in this situation, obviously, the higher the number, the worse it is. There's no scenario in which more pain is better than less pain, okay? That's severity. Timing, okay? T is for timing, and what we mean by that is how long does it last? Is it constant or intermittent? And then the other thing when it comes to chest pain in particular is I want to know, how did it come on? So when we talk about the heart or any type of cardiovascular pain, I will ask you, when it comes on, does it sort of ramp up, growing in intensity, and then sort of resolve, ramping down in intensity? Or does it come on like a light, boom, there it is, and then we close the switch and there it goes away? Because the heart doesn't work flip, flip. Okay, so if it comes on and then it's gone, a lot of times someone will be working out and they go, ugh. They go, ugh. And that more often than not is going to be something musculoskeletal as opposed to something cardiovascular related. So, and then finally, I stands for intervention. So I will say, what do you do when this happens, or did you take any medication? So somebody will say something like, yeah, I know I have angina. So what I do is usually I walk up, 2 flights of stairs and I get this chest pain, and it's 5 out of 10 severity, and what I do is I take a nitroglycerin and it goes away. So that's your intervention. Or I'm walking in the street, all of a sudden I feel this bronchospasm, my airways tighten up and I'm short of breath, and I take my albuterol, and within about 5 minutes my chest starts to loosen up. So again, this is my way of thinking about symptoms. It's not my way, I didn't invent it, okay? I learned it as an EMT working EMS in New York City. But again, if you can go to your doctor and give them this information, as opposed to, oh, I don't understand what happened. I was, I had this chest pain and I was getting sweaty and I thought I was gonna throw up and this and that. Give it to them in an organized way. And what I do even is I have sheets ready that if a patient starts to tell me something like this, we pull out an OPQ RSTI sheet where we can start recording the data in this way. So again, one more time, onset, what were you doing at the time that this occurred? P, is there anything that makes it better or worse, provocation or palliation? Q is quality, can you describe the quality of the discomfort? R is radiation, does it stay in one place or does it move anyplace else? S is severity on a scale of 1 to 10, 10 being the worst pain, 1 being minimal pain, 0 being zero pain. How bad is it? T is for timing. How long does it last? Is it constant or intermittent? I is for interventions. What did you do about it? So I hope that helps a little bit. Another thing I want to talk about is very often I will see somebody report a symptom, okay? And then a lot of people will say something like, oh, that is this. Again, what that is it's, foot fungus, and you should rub some Desenex on your feet, and that'll make the athlete's foot go away. Okay, but I want to point something else out. So just because you had a similar symptom in Wyoming, it doesn't mean that Becky from Utah, when she has a similar sensation, has what you had, and therefore should take what you took, because it may be something completely different. Okay, I would never, when people, if you notice when I talk online, I'm always very careful not to say you have this. I'm always careful to say what it could be is this, it could be this, this, or this. You might want to ask your physician if this would be of benefit, if a sleep study would be of benefit, if a stress test would be of benefit, if you might, instead of taking your inhalers at night, try them in the morning, okay? And the reason for that is because I don't know you, okay? I haven't seen you, I haven't examined you, and I would never assume, I could make a corny assume reference, because you know what they say, but I would never make an assumption that I know what's wrong with you, okay? I'm not with you, I haven't seen you, I am not your physician, and I'm not a physician. I'm a cardiovascular and pulmonary physical therapist and an EMT, but the thing is that I can't assume that because you're having a symptom or experiencing a chain of events that is similar to what I may have experienced 3 years ago, and it was this, that it's the same for you. And the other reason why that's important is because sometimes the treatment for one thing can be the exact opposite treatment for something else, and can actually be harmful for you. I want to give one more example. I have a question, maybe it's just old age, but when I'm typing or writing, it seems like I have problems spelling or putting the right words together in a sentence. I have to really stop and think about what I'm spelling or writing. Could stress cause this? My mind wants to tell me that I could have had a light stroke, and that scares me. Any thoughts on this? Oh, I do want to mention how forgetful I am as well. Now, I don't even remember writing this, okay? That should tell you something, okay? However, just kidding, okay? Here's the thing, so let's go to this. Maybe it's just old age, okay? A lot of times I'll hear somebody chalk something up to old age. They'll say, you know what? That's your age. But think about it like this, okay? First of all, this person, I don't recall if they said they were 59 years old or 69 years old, but even if they're 69 years old in today's times is relatively young. And so I wouldn't chalk anything up to just old age at the age of 69, okay? I tell someone who's 69 that your age is not a factor in anything we do, and we can definitely rehabilitate you very strongly and not worry about your age. My average patient is 80 years old, okay? Today we had 6 people over 90 in the Pulmonary Wellness and Rehabilitation Center gym, okay? And the other thing to think about is that we all know somebody who's 97 years old and still surfs or still skis or this or that. So if the point is if that there are people who defy that, okay, then it can't be just your age. And if you're asking a question like I am forgetful or I can't remember a word, certainly these things can happen as we get older, but it could also be a sign of something else. It could be a sign of something neurologic, okay? Could stress cause this? Absolutely, okay? Very few of us function at our best when we're under stress. We forget things, we could have word finding difficulties, we could be more anxious. But again, I don't want to take a chance that you do have a neurologic problem and we're going to miss it. Or I don't want to take a chance that you could be a candidate for a stroke, and so you're going to wait a month to see your doctor or wait to see if it happens again. I want to know today that your carotid arteries are open enough and you're not going to flip a clot to your brain, okay? So again, if it's something that is a potential life and death situation, your heart, your brain, your lungs in many situations, okay? Do not wait. If your doctor's appointment is in 10 days from now, a lot could happen in 10 days, okay? And I don't want to speak to you on the 9th day and say, damn, well, he was just going to go to the doctor tomorrow, which is why I will always say to people, err on the side of caution. Now, I want to go through one other thing, and then I'm going to go to questions from the audience, okay? When I see a new patient, there's something called a systems review, okay? And this is a series of questions that I ask my patients in an effort to elicit any problems that A, may have been missed by somebody else, or that may present a problem during the rehab program. So in other words, a lot of my patients come to me in their 70s, 80s, 90s, and I say, do you exercise? And they say, well, I haven't exercised since I was in my 40s. So if you're 90 and you haven't exercised in 50 years, then we don't know exactly what's going to happen when you start exercising. So I want to make sure that I am going to do what I call risk stratify my patient to minimize the chance of them having an emergency during exercise, okay? Now, that being said, okay, exercise doesn't usually cause an emergency to happen. Exercise might bring out an emergency that may have been waiting to happen anyway. And if somebody's going to have an emergency, I'll tell you the truth, I'd rather it happen here at my center where at least I can help you within the first 10 seconds as opposed to walking across the street in a department store where it might be 15 minutes before EMS gets to you. So here's some questions to think about, and I'll tell you why I ask the questions I do so that you could start to put it in a framework as you think about your own signs and symptoms and as you think about the questions that you can ask your doctor, okay? So when we talk about the systems, okay, these are the systems I look at. The neurologic system. There's something called HEENT, which means head, eyes, ears, nose, throat. The pulmonary or respiratory system. The cardiovascular system, the gastrointestinal system, the genitourinary system, the vascular or circulatory system, the hematologic or blood, the endocrine system, the dermatology or the skin, the musculoskeletal system, and psychiatry and psychology, okay? So there are certain things that are common when we see people of a certain age, when we see people who have a certain classification of disease, that have certain diagnoses. And again, if I am going to get somebody exercising or if I'm going to encourage somebody to make a lifestyle change, I want to make sure I have a very good understanding of what's already happened to them and what those potential risk factors are. So let's start with the neurologic system. And I'm going to talk to you as if I'm speaking to a patient that's in front of me. So I will say, do you have any neurologic problems? And since most people might say, what the heck is a neurologic problem? I will say, have you ever passed out? Dizziness, stroke, seizure, okay? And then I'll ask about something called neuropathy. Now, let's talk about these individually. So have you ever passed out? Somebody can pass out from a neurologic reason. Somebody can also pass out from a cardiovascular reason. Someone can also pass out from a respiratory reason if they're hypoxic. Someone can also pass out for a circulatory reason, okay? So an example of somebody passing out due to a neurologic reason might be a seizure. Somebody passing out due to a neurologic reason might be, a neurologic related to a cardiopulmonary reason might be that they drop their pressures. That's circulatory, and it has to do with the cardiovascular system. So I want to know, have you ever passed out? Do you ever get dizzy? And when I talk about dizziness, okay, there's different types of things that we're talking about. So a lot of times somebody will say, I get dizzy when I change position. So when I go from lying down to sitting up, I may get dizzy, okay? And I want to know what's causing that. Is it cardiovascular, meaning that your heart is not strong enough to push blood to the legs and keep it coming back up? Is it neurologic, okay? Is there something related to my inner ear that might make me dizzy? Or just lightheaded? Do I get vertigo, okay? Meaning, does the room spin? I want to know, have you had a stroke, okay? And when it comes to stroke, okay, there's a similarity with other systems, okay? And what I mean by that is this is one of the few assumptions I make, okay? But it's an assumption on the side of caution. And what I'm going to say about this is that I make the assumption that if somebody has atherosclerosis in one area, that they probably have atherosclerosis in another area. And the places that we worry about most are atherosclerosis of the coronary arteries, atherosclerosis of the carotid arteries in the neck, okay, because plaque there can flip off and go into the brain and cause a stroke. I worry about atherosclerosis of the brain and the cerebral arteries. I worry about peripheral arterial disease, so atherosclerosis in the lower extremities that will lead to something called claudication, meaning a cramping in your calves when you walk. And then I want to know about other things. So we talk about neuropathy. Neuropathy is kind of a general term. Somebody will say, I get numbness or tingling in my hands. I get numbness or tingling in my feet. And that could come from many different things. That could be neurologic in nature. It could be that you have a compression somewhere along your spinal cord. It could be that you have a disc bulging and pressing on a nerve root. It could be related to circulation, okay? There's a lot of different things. So again, this is all through the neurologic system, but I'm asking about your symptoms so that I can try to plan out and make sure that I'm not missing something that's going to be dangerous for you once we start your rehab session. So again, do you have any neurologic problems? By that I mean, have you ever passed out, dizziness, stroke, seizure? Do you get a lot of headaches? Okay, if somebody gets a lot of headaches, many causes, okay? Could be related to something in your brain, could be related to something in your neck, could be related to stress, could be related to your circulatory system, could be related to the way you sleep. So again, the reason why I'm pointing all these things out is because I don't want you to have this knee-jerk reaction. You're wheezing, you must have asthma. Your knee hurts when you walk upstairs, you must have osteoarthritis. You have a headache, you must have a brain tumor, okay? My point in telling you this is that there is more than one way to skin a cat, and for each symptom that you have, I can assure you that there are many possible causes of it, and we want to make sure that we're not missing the right one, and that we're not assuming it's the wrong one, okay? So do you get a lot of headaches? How is your vision? Do you have double vision or blurry vision? Do you have cataracts or glaucoma? Do you wear glasses or contacts? How is your hearing? Do you have any ringing in the ears? What about vertigo? Does the room ever spin? Do you have any sinus trouble? Do you have a sore throat or hoarse voice? And do you wear dentures? That's head, eyes, ears, nose, throat, okay? So one more time, do you get a lot of headaches? How's your vision? Do you have double vision or blurry vision, cataracts or glaucoma? Do you wear glasses or contacts? How's your hearing? Do you have any ringing in the ears? What about vertigo? Does the room ever spin? Do you have any sinus trouble? Do you have a sore throat or hoarse voice? Do you have dentures, okay? And you see that a lot of these things can be cardiovascular in nature. They could be respiratory in nature. They could be GI in nature. They could be from acid reflux. And again, I want to make sure that I'm getting things right. Next, I'm up to the pulmonary system. Have you ever been told that you have asthma or COPD, emphysema or chronic bronchitis? And I say it because sometimes people will say, what is COPD? Okay, that question comes up all the time. COPD, emphysema or chronic bronchitis, okay, and or chronic bronchitis. Have you had pneumonia in the past? Have you ever been intubated? Are you coughing? If you're coughing, I want to know, are you bringing up mucus? If you're bringing up mucus, is it thick or thin? Is it clear, white, or colored? And if you're not bringing up mucus, is that because you don't have a lot of mucus, or is it because you have it and you're not able to bring it up where you can clear it, making you more prone to pneumonia, okay? Are you short of breath? Are you wheezing? Have you ever had any heavy exposure to Dester chemicals? I saw a patient the other day who was a trackman in the New York City transit system for 25 years. So he must have been exposed to every chemical under the sun. So again, that's my respiratory system. My cardiovascular system. Do you ever get any chest pain or pressure? Do you ever get any squeezing feelings in your chest? What about palpitations where you're suddenly aware of your heart beating quickly? When you lie in bed at night, are you able to lie flat? Do you ever wake up in the middle of the night short of breath? Do your feet ever swell? Have you ever been told that you have coronary artery disease, atherosclerosis, heart disease? Have you ever been told you have congestive heart failure? Have you ever had a heart attack? Do you have high blood pressure? Do you have high cholesterol? Have you ever had an arrhythmia like atrial fibrillation? Do you have pulmonary hypertension? And again, just because somebody comes in with does not come in with a diagnosis of coronary artery disease, okay, that doesn't mean they don't have coronary artery disease. And let me let you people with respiratory disease in on a little secret, okay? A lot of times, we discover heart disease here or heart problems here because for the first time in 20 years, okay, a person is able to do enough exercise to actually elicit a cardiac symptom, whereas before they may have been too short of breath to get up that second flight of stairs. So their heart situation never even came up because shortness of breath was their limiting factor. But now that we're starting to get them in shape, okay, now their heart things are coming up. And that's why a lot of time, that's why we use telemetry, EKGs on every single patient every time they exercise. How many people said to me, you don't need telemetry, you don't need an EKG, you have pulmonary patients, not cardiac patients? Exactly why I want to have an EKG on every patient, okay? So again, do you ever get any chest pain or pressure? Do you ever get any squeezing feelings in your chest or palpitations? When you lie in bed at night, are you able to lie flat? Do you ever wake up in the middle of the night short of breath? Do your feet ever swell? Have you ever been told you have coronary artery disease, heart disease, or atherosclerosis? Do you have congestive heart failure? Have you ever had a heart attack? Do you have high blood pressure? Do you have high cholesterol? Okay, and when we talk about coronary risk factors, okay, the more of them you have, they don't add up, they multiply. So if you have 2, it's worse than having 1. If you have 3, it's much worse than having 2. And if you have 4, you better get yourself moving in an effort to minimize these risk factors. I'll just take a little aside right now and talk about cardiac risk factors for a couple of seconds, okay? When we talk about cardiac risk factors or risk factors for heart disease, they can be broken down into what we call non-modifiable and modifiable risk factors. So the non-modifiable risk factors are things like age, gender. With the older you get, the greater chance of heart disease. Gender, okay, males start off with a higher risk, females eventually catch up to us and surpass us, okay? Ethnicity. Okay, so African Americans, highest risk of heart disease, more so than whites, and and as we talked about, and also family history. So if you have a strong family history of heart disease, that's going to make you more prone to heart disease. So again, non-modifiable risk factors. Age, when I figure out how to modify that one, the pulmonary center is going to go to gold ceilings. Okay, gender, and I'm not talking about which bathroom do you use or that whole fight right now. I'm talking about, what you're born as far as a risk factor for heart disease. Race, okay, and ethnicity, and also family history. So that's the non-modifiable. Modifiable are things like high cholesterol, high stress, okay, we call sedentary lifestyle, obesity, diabetes, high blood pressure, things like that, and those are all modifiable risk factors. So the more you have, the more in the back of my head I'm thinking this person may have heart disease. After the cardiovascular system, I'll go to the gastrointestinal system, okay? Have you lost or gained any weight? And we talk about in many of the webinars, we talk about the importance of respiratory patients and pulmonary patients being the right weight, okay? We know that very often when you work hard to breathe, keeping weight on can be a problem. We also know that obesity can be a problem because it makes it more difficult for you to breathe. Other things, nausea, vomiting, diarrhea, constipation, all these things can have an impact on how well you breathe. Think about it. If you haven't had a bowel movement in 3 days and your stomach is rigid with with food that you can't expel, the diaphragm has to work that much harder to get that out, okay? Or rather to contract downward so that you could take a deep breath, okay? Diarrhea can cause you to lose a lot of fluid, can cause you to lose electrolytes. Then I ask about acid reflux because acid reflux is something that's very, very common in respiratory disease. Some of the symptoms of acid reflux can look like respiratory symptoms. Some of the symptoms can look like cardiovascular symptoms. And the other thing is that reflux can actually worsen your lung disease. GU, so do you go to the bathroom a lot? Are you incontinent? Are you taking a diuretic? The vascular system, so I say, do you have any vascular or circulation problems? Have you ever been told that you have peripheral arterial disease? And again, atherosclerosis in one place, okay, I feel like a flight attendant, but leads me to believe that you may have atherosclerosis in other places, okay? Do you have any blood disorders? Anemia? Do you bruise easily? Do you bleed easily? So that could lead us to the question, are you on any blood thinners? Have you been on steroids? Do you have any thyroid trouble? Are you diabetic? Do you have osteoporosis? And all of that falls under endocrine system. Do you have any skin problems? Do you have any musculoskeletal problems? And just in case you don't know what musculoskeletal problems are, I'll say, do you have any joint swelling, stiffness, pain, arthritis? And the reason I want to know that is because if you have a frozen shoulder, then I have to think twice about putting you on a machine that's going to aggravate your symptoms. Or if you've had 2 total hip replacements, I have to think twice about which bicycle I can put you on safely or what might aggravate your symptoms. And then finally, are you depressed or are you anxious, okay? It can be very isolating, it can be depressing to have a chronic disease, it can be very anxiety provoking to have a chronic disease. So again, my point in telling you all this is that we shouldn't be diagnosing each other on Facebook, okay? We can point out the fact that, hey, I had something similar to that and it turned out to be shingles, or it turned out to be gout, or it turned out to be a pulmonary embolism. But we don't want to say, well, I had this, therefore you have this, and you should do what I did, because it can be harmful for the person. So again, just to reiterate and show you, how quickly this can be done and how worthwhile it is, this is my systems review. The first thing I do, I'll ask a patient, what brings you in today, okay? There's something called a chief complaint and the history of present illness. I'll give my patient a total opportunity to tell me everything they want to tell me about what brings them in today and what I can help them with before I start asking questions. Then I want to know about their medications. I want to know all the medications they're on, okay? And a lot of times through the medication list, I can determine what do they have? What are their diagnoses? And then I'll go through my systems review. And it sounds like this. Do you have any neurologic problems? Have you ever passed out, dizziness, stroke, seizure? Do you get a lot of headaches? How's your vision? Do you have double vision or blurry vision? Do you have cataracts or glaucoma? Do you wear glasses or contacts? Is your hearing okay? Do you have any ringing in the ears? What about vertigo? Does the room ever spin? Do you have any sinus trouble? Do you have a sore throat or hoarse voice? Do you wear dentures? Have you ever been told that you have asthma or COPD? Emphysema or chronic bronchitis, pulmonary fibrosis, pulmonary hypertension. Have you ever had pneumonia in the past? Are you coughing? If you're coughing, are you bringing up mucus? Is it thick or thin? Is it clear, white, or colored? Shortness of breath, wheezing. Have you ever had any heavy exposure to dust or chemicals? Do you ever get any chest pain or pressure? Do you ever get any squeezing feelings in your chest or palpitations? When you lie in bed at night, are you able to lie flat? Do you ever wake up in the middle of the night short of breath? Do your feet swell? Have you ever been told that you have heart disease, coronary artery disease? Have you ever been told you have congestive heart failure? Have you ever had a heart attack, high blood pressure, high cholesterol, pulmonary hypertension? Have you ever had an arrhythmia? Do you have any GI or stomach problems? Do you have any urinary problems? Do you have any vascular or circulation problems? Do you have any blood disorders? Do you have any thyroid trouble? Are you diabetic? Do you have osteoporosis? Do you have any skin problems? Do you have any musculoskeletal problems, joint swelling, stiffness, pain, arthritis? Are you depressed? Are you anxious? 10 minutes, if they don't have any of it, I've just learned a whole lot of information about them. All right. Questions. I'm going to go to audience questions. Hi, I've been at Mayo for 10 days trying to figure out why my oxygen sats drop. I'm on 24/7 oxygen, 4 liters per minute at night, and as needed to keep oxygen sats up during the day. They find no explanation, and I'm wondering if you have any thoughts or ideas. Okay, so if you've been at Mayo for 10 days and they don't know why your sats are dropping, you need to be on Gregory House MD if the series was not canceled. Do I have any thoughts? Okay, the obvious thoughts are, do you have a respiratory problem? Okay, do you have pulmonary hypertension? Do you have a diffusion problem? But again, I find it hard to believe that through 10 days of workup at the Mayo Clinic that they wouldn't have done all these things. So unfortunately, I can't say that I have anything specifically to add to that. Okay, have you had an infection recently? Those are the main ones. So heart disease, lung disease, congestive heart failure, pulmonary hypertension, diffusion issues, pulmonary embolism. That's the differential diagnosis. Those are the things that I would be thinking of for somebody who's got low saturation. By all means, and Donna, I hope that when they figure this out, please send me an email at noah@pulmonarywellness.com or hit me up on Facebook, and please tell me what it was, because again, Mayo is the Mecca. So if after 10 days at Mecca, that you don't know why your oxygen sats are dropping, this is something very, very unique. But I wish you the best of luck. All right, why is it harder for you to breathe when lying down flat on back, yet on your side it's easier? Okay, Helen, there are a number of potential answers to this, okay, and it's not going to be the same for everybody. Okay, number one, it could have to do with the lungs becoming more compressed. In a lot of people, if you have issues with fluid overload or congestive heart failure, okay, when you lie down on your back, that's going to increase the work against which the left ventricle has to contract in order to pump blood to the rest of the body, and we can actually have a backup of blood into the pulmonary circulation. On your side, for some people it's easier, okay, but the other thing is when you lie down on your back, okay, again, this, as I mentioned before, this puts the diaphragm in a poor mechanical advantage, okay. The diaphragm now has to work against increased gravity, okay, increased against gravity. And the other thing about lying on your side is that we drop the abdominal contents, okay. Right now when you lie down on your back, everything in your abdomen, particularly if you're overweight, is pressing down on the path which the diaphragm wants to contract against. When you lie down on your side, those abdominal contents drop out of the way and clear the way for the diaphragm to move smoothly. Okay, Glennis, good night. You need to go to sleep and we'll watch this later. I wish you a good night's sleep. Okay, June, question. I clear my throat and bring up red blood. Not every day, but a couple of days last week. Okay, the blood is mixed with mucus. So in this situation, I think I would want to unquestionably see a doctor about this. Let them look at your throat. Now, sometimes you can cough up little specks of blood and this means nothing, okay? It could just be that the airways are irritated. It could be that you're dry. It could be that you've been coughing a lot. But blood in the sputum can be a sign of something more serious, like infection, there are a whole bunch of things it could be. But my first order of business, I think I would want to see my doctor. I would want to say that I'm having blood in my sputum. I would ask for a chest x-ray to see if there's a potential for infection. Is there any type of pneumothorax or anything like that? And I would also ask if it would be worthwhile to do a blood culture, and both of which I think would be worthwhile. So I don't have an explanation, June, but I do say that it's not something you want to sleep on, and by sleep on, I'm not talking about Glennis. I'm talking about it's not something you want to wait on, okay? Blood in the sputum is something that has the potential to be something serious, and you don't want to wait on that. So I'd want to see my doctor, ask about a chest x-ray, ask about sputum culture. Carol, my specialist changed me from 5 years of Atrovent and Advair to Respimat and Alvesco. Okay, so 2 puffs each at the same time every day. Is there anything I should know about taking these puffers? Okay, let me just do a quick, because when I'm doing these things, it's very easy to get disoriented. So from Advair and Atrovent. So when you say Respimat, okay, Respimat isn't really a medication. Okay, what it is it's the delivery system. So I'd need to know what the name of the medication that you're on. Okay, so things we'll see like a Spiriva Respimat, and there are others as well. But Alvesco basically. Alvesco is a corticosteroid. So the corticosteroid is going to replace the corticosteroid in the Advair, And then again, I'd need to know what are the other medications that you're taking in the Respimat. But I would want to take the Alvesco last. I'd want to take the bronchodilators first in order to open up the airways so that you get the maximum benefit from the Alvesco, which is the steroid. Next question from Mary. I have discomfort along the top of my breastbone across my chest. Could it be caused by inflamed bronchial tubes? So you're saying across the top of your breastbone, could it be inflamed bronchial tubes? It could. Could it be costochondritis? It could. Could it be something else? Yes. Okay. So I would, another thing about signs and symptoms. So when, a lot of times I'll ask somebody, does it feel like it's inside or outside? And I'll also palpate the area, okay? So if I give pressure, so if somebody says, I have this discomfort along the top of my sternum and across my chest, or the top of my breastbone and across my chest, if I press on it and I can reproduce that discomfort, then I know that's not your heart, because I can't reproduce angina by pressing on your heart, okay? But that points more so to a musculoskeletal issue. So it could be inflamed bronchial tubes, it could be costochondritis, it could be arthritis. A chest x-ray could very well answer all of those questions for you, and that is what I would ask my doctor about. Next question. This is, I have a lung nodule that my specialist doesn't know if it's cancer or a mucus plug. Rather than doing a bronchoscopy, he wants to see if he can get the information he needs in a different manner. Today I spoke to the respiratory tech that will be doing the procedure of inducing sputum samples using a hypertonic saline solution. So what that's called is a sputum induction. There are apparently 5 separate things he's looking for in sputum samples. I didn't write them down, darn it all. And apparently, in addition, a separate kit will be used. Actually, I can cough up sputum on my own, and it's puzzled my respiratory tech why he asked for sputum induction. I'm hoping you can shed a little more light on this for me. I have emphysema and bronchiectasis, FEV1 25%, 3 CAT scans over a year and a half. The right middle lobe has shown a nodule that may be questionable. Last CT last month, the other CT a year, the other 2 a year and a half prior. So here's something. So a lot of times when somebody looks at a chest x-ray and sometimes even a CAT scan, they can see something that looks nodular, or it might be a nodule, it might be a mass, or it might be mucoid impaction, okay? A sputum induction is a procedure in which they actually will loosen up the secretions, making them easier for you to cough them out, and then that sputum will be collected and go through a sputum culture. However, if you have mucus impaction, meaning that mucus is tight and clogging an airway and thick and something, and it's really hard to move, that may not come up with a sputum induction test, okay? It may not be vigorous enough. So what a lot of the doctors in New York City will do is they'll send the patients to us for either training in one of the positive expiratory pressure devices, like an a cappella valve, like an aerobica, like a lung flute, or what's even better for this is actual chest therapy session in which Marion Macklis will actually do the percussion where we're actually manually trying to beat that mucus out of the person. And sometimes we'll see that person every day for a week, repeat the chest x-ray, and sometimes what looked like a mass or what looked like a nodule is gone completely because she was able to help them clear that mucoid impaction. So I hope that helps. Next question from Sharon. Hi, Sharon. What aerobic exercise should be done besides treadmill if you don't have pulmonary rehab available? I do not have rehab, but have a treadmill and am stage 4 emphysema. Sharon, I have your medical history memorized by now. Treadmill is awesome, okay? If I only had a treadmill, I could still get a person into just as good a shape as if I have 7 different aerobic machines. So if it's only treadmill, that's great. The other machines are great cross trainers. So examples, exercise bike, either recumbent or upright, upper body ergometer, the UBE or the U Better exercise. New Step is great. We use elliptical machines here. We use our Armorcise program, which, yes, believe it or not, by the end of the summer, I will have a video for you to do Armorcise along with. or just going out and walking, okay? Pool, water aerobics are okay if you can tolerate the water and the chemicals. But again, treadmill is my favorite. Walking outside is my second favorite. Just, working to gradually increase your time and intensity over time. All right, next question. And again, incidentally, Sharon, there are many hours of exercise webinars in my archives, okay? It's the number one thing that I know the most about, that I speak about all the time. There's probably a good 8 hours of webinars on exercise. So when in doubt, go to the web archives at www.pulmonarywellness.com. Shameless plug, because I love shameless plugs. All right, next question. That there was an internet, my tech mentioned it, maybe what is referred to as a thumbprint impression or something. Okay, best products to conquer dry mouth, okay? There is a product that I'm drawing a blank on the name right now. It's sort of like a mouthwash, although I like mouthwash. Let me do a quick Google search and see if that name comes up. Dry mouth solution. Biotene, there you go. Biotene, send me my check for endorsements, okay? There's a rinse called Biotene, and that people get very good success with. We also give our patients Ricola cough drops. Ricola. We also like Fisherman's Friend cough drops, and also make sure that you're drinking plenty of fluids. All right, but the one I was trying to think of is called Biotene. Next, my doctor is trying to call every symptom anxiety. I had a pulmonary embolism, pelvic and thigh clot. I have been to a pulmonary doctor who did PFTs and looked at CAT scans. They say I have bronchial tubes that inflame, probably off and on for all my life. A cardio has done EKG, echo stress test with Definity. Stress echo test with Definity. I'm not sure what you mean by Definity. I pushed for more tests. He has me doing an event monitor. I had a 24-hour Holter that only showed PVCs and SVTs. My family history is a lot of cardiac stuff. I have a lot of symptoms, yet no one can catch anything. All right, so that's a good point. And this is another reason why I love monitoring patients with EKG during pulmonary rehab, okay? And EKG is only as good as the rhythm that you get while the EKG is on. What do I mean by that, okay? I mean that if I am taking a photograph, I can be like, hey, and somebody puts the camera down, and then I can stick up my middle fingers or give somebody the horns or give them the stink eye, and that could be totally missed by the camera. Same with an EKG. So a lot of times somebody will report suspicious symptoms to me, and I'd say, I really would like your heart worked up, and they go to the doctor and say they did an EKG and everything was normal. All that means is that an EKG was normal at that time when that tech pressed that button doing the EKG. Okay, and if you have arrhythmias or you have chest pain that comes and goes, it's probably not going to be picked up during that EKG. Now, if you had a previous heart attack, that will be picked up during an EKG. If you're having coronary ischemia, meaning that your heart is not getting enough blood flow at the time that you're getting the EKG taken, then it will be picked up, okay? Other than that, an EKG is limited. So I don't think every symptom is anxiety, although a lot of symptoms can be anxiety provoking, and then anxiety can reinforce those symptoms. So I like the idea of an event monitor, okay? Sometimes a 24-hour Holter is not enough time to catch what you're saying. So if you have a family history of lots of cardiac stuff, you've had most of the tests that I would recommend. My favorite test, because it's non-invasive but still gives us a ton of information, is a stress echo, okay? If you're really worried about coronary disease, okay, and you have a really strong family history and you have a lot of risk factors, I mean, if you really want to know for sure, it would be an angiogram, but an angiogram is invasive. It comes with a lot of risks in itself, and I could understand that your doctor may not want to do an angiogram, but that would be the next step. All right, Carol, my mucus is a normal color for a person with very severe COPD. I don't know what that means, but okay. A whitish, light yellow color, sticky, but not always really sticky. Once in a while, it's a light green or deeper green. Usually that leads to needing an antibiotic, but sometimes it just lightens on its own. Last exacerbation, October 2015, and again, April 2016, Biaxin and levofloxacin cleared them. Okay, I don't see a question in there, okay? But let me just talk very briefly about mucus, okay? So thin is always going to be better than thick. Light is always going to be better than dark. Clear is always going to be better than white. And white is always going to be better than color. Yellow towards green, definitely infection. Red could be blood or strawberry jello. No joke. But that's the basics of mucus. Next question, Denise. Can taking probiotics help with breathing by alleviating stomach, lower GI issues, and bloating? I say yes. And I think also that probiotics is an area of medicine that's going to get so much more play, and it's already starting to over the next several years and decades, because so much the gut, there's a lot of people that believe the gut is the key to health, is the key to inflammation. So absolutely, I think it can help with those stomach issues. I think it can reduce gas, it could reduce bloating, it can reduce your chances of developing infection in your stomach. I think it can reduce your chances of developing any type of inflammatory bowel diseases. I think it can probably, although I've never read anything about it, there may be something out there, reduce your chances of cancers. And I think it decreases overall inflammation in the body. Okay, inflammation in one place can increase inflammation in other places, and also lower your resistance and ability to fight inflammation and fight infection. So I think probiotics are great. I take them myself. The one I take is called VSL number 3, and the reason why I like that one, it's a powder. Okay, it's expensive, I'm not gonna lie, but if your probiotic doesn't have to be refrigerated, then it's not really live cultures, or it's not really the most ideal probiotic, okay? The VSL3 was recommended to me by the GI team at Mount Sinai Medical Center, and it's the only one that Mount Sinai recognizes in their formulary, because at the time that they recommended it to me, it was the only one where they had randomized control studies on it. So yeah, I'm a big fan of probiotics. Danielle, do I have any advice for people with bad posture? Same advice as your mom and dad gave you. Stop slouching. Just kidding. What can be done for better posture so a person can breathe better? All right, so let's talk about that for a little bit. So anytime you're crunched over like this, it's going to make it more difficult to breathe. So let's look at what I'm doing right now. I'm flexing at the hips, okay? And I am leaning forward and crunching everything up. So first thing I want to do is I want to sit up straight, okay? I want to open up my chest so that I could take a deep breath, and I want to watch this, okay? As human beings, we do almost everything in front of us, okay? We work all in front of us, okay? Our back muscles tend to get weaker. Our chest muscles and anterior front shoulder muscles tend to get stronger and tighter because of everything that we do here. So what do? You have to sit up straight. It's helpful if you put a little towel roll behind your low back. That will put you in your natural curves, where you have a normal cervical lordosis, a normal meaning that it curves in, a normal thoracic kyphosis, which means it curves out, and then a normal lumbar lordosis, which means it curves back in again. So put a little, and this seat is actually, it's a custom seat designed just for good posture, but what you want to do, make sure that you have this curve in your low back, up straight, shoulders back, constantly squeeze your shoulder blades together. And when we do our exercise, we always have people work the back muscles as a priority over and before the front muscles, because those muscles are going to be weaker. So it's about muscle imbalance, okay? If you spend a lot of time at the computer, you have to spend twice as much time stretching those front muscles, strengthening those back muscles, and there are certainly exercises you can do for that. And the other thing that's very important is that posture is not something you could do for 5 minutes a day. Posture, in order to really improve your posture and correct muscle imbalances and make a change that can be a lasting change, what has to happen is you have to become aware of your posture at all times during the day. That means when you're sitting at the restaurant, when you're sitting in a taxi, when you're sitting at your desk, all these different things. And Chris just sat up straight. So it's something that's a day in, day out type of thing, and it's very difficult to it's a very difficult thing to change, but it is possible. Next question, and it's a follow-up from Donna. Thanks, they have sure done all those tests but no luck yet. Please, I'm fascinated by that case, so I know Mayo is going to figure this out for you, and when they do, please let me know what it is. Next question from Amanda. The doctors said I had CAT scans, echoes, PFTs done. I am short of breath a lot, lots of chest pressure, tightness when I wake up, my legs swell. I'm on my 4th UTI since December. They say PE came from surgery. My hysterectomy was in November. I'm really tired of them saying it's all just anxiety. How do I get them to listen and do more tests? I mean, look, you're short of breath. Short of breath can be anxiety, but it could be something serious. Shortness of breath is not something I ignore. It could be heart, it could be lungs, it could be a number of different things. Chest tightness when you wake up, your feet swell, that's telling me you could have something related to your kidneys and your renal system, could be related to congestive heart failure. I'm not saying this is what I think it is. These are the differential diagnosis things that pop into my head. Like I said, it's a good thing I watched a lot of House MD, but again, you're on your 4th UTI. I mean, I want to know things. I want to know I want to know more about this. Okay, you've had echoes, you've had CAT scans, you've had EKGs. Is it possible that you're just out of shape? Yeah, that's another possibility. That could be causing your shortness of breath. That could be causing your tightness when you wake up. That could, being out of shape doesn't cause edema in your legs. Having weak leg muscles, the way that edema gets back up to the system is by the calf muscles contracting and relaxing. But again, I would want to know, why do you have all that fluid on board? What's going on? The things I'd want, you've had CAT scans, you've had echoes and EKGs. Have you ever had a stress echo? That's something I would want, because I'd want to know, a lot of people can have an echocardiogram and they can have a perfectly normal echocardiogram at rest, because we know that heart function is based on supply and demand. So whereas the heart may be adequate to supply the demand of just sitting and doing nothing, it may only be during exercise, when the demand increases, that the supply is no longer adequate. So I would want to know, I'd want a stress echo. I'd want to know what's going on during exercise, and I think that may shed some light on it. So John Linnell, I always say there's no stupid questions, okay? But the question is, at what point will Noah begin wearing a Yankee jersey? And that point will only be after I'm unconscious or dead, and somebody puts that jersey on me, okay, against my will. So the answer is never. But this jersey that I happen to be wearing tonight is a memorial jersey. So I'm wearing it for a reason, but I don't care what the reason. I would almost never wear a Yankee jersey unless there was a super special reason for me to wear it. But no disrespect to Yankee fans, but it's just not who I am. I'm a Brooklyn boy, and the Mets are my team. All right, another thing. Sorry, John, but other questions. Another thing. I had a sleep study which says I had no REM sleep and I have extreme fatigue that is crushing. Okay, so here's the thing. So a sleep study. There's Amanda. There's enough there that makes me say, okay, it's not, I definitely wouldn't say that what you're experiencing is anxiety only, okay? There's nothing there that says you have an anxiety disorder and you have no physical manifestations of it. But what I would say is, when the doctors that you're used to talking to aren't listening anymore, or have kind of put you in a box of this is what it is, and I'm no longer willing to look at any other possibilities of it, that's where I think a second opinion is really important, okay? And what I do when I can't figure something out, for myself, and unfortunately I've had a few health issues myself in the last couple of years, but what I did was I went online and I put best internist New York City, and I wanted to find who is the person that's going to be able to take all of these test results, look at each one individually, and then come up with something and a new direction that hasn't been looked at before. So, again, I don't think this is all anxiety. I think you want to go a little further with this. Okay, so Danielle, do you have any knowledge about vitamin D being good to help respiratory inflammation? I don't know that there's specific vitamin D3 respiratory connection that's been proven, although I'm sure there is one. Vitamin D3 deficiency, I think, most of us don't get enough sunshine, and if we don't, I think vitamin D3 supplementation is important. Next, okay, so continuing it with Amanda, I broke my back in 2012. Another thing, I feel like I have something in my throat that I can't get out. My resting pulse can go from 120s to 60s really fast. Again, you have a very complex situation, Amanda. You need a good internist that's going to work with a good cardiologist, that's going to work with a good pulmonologist and endocrinologist. And in looking at your whole situation, I think I might go endocrinologist. And you definitely need more workup. Okay, next, Barbara Joe. If I have rare aspergillosis, will it grow into full-blown condition? Why won't they treat me now to cure it before that happens? I don't think there's any way to know the answer to that. And as far as why don't they treat you now, I'm not by any means an expert on aspergillosis, and it's not something that I see very often, so I would have to punt on that question. If any of my RT people are watching, or if you would like to post that on Facebook, I will ask Mark Mangus or Mike Hess or one of these other guys or gals, Kelly Welton, to ring in on aspergillosis. Next question. The bronchoscopy could be done but it would be tricky with my damaged lungs. Yeah, bronchoscopy is invasive. If you don't have to go invasive and you can find something out non-invasively, it's always going to be better. What is my feeling about amiodarone-induced pulmonary toxicity? I don't like it. I was on a vent for 4 months after complicated heart surgery. Doctor came in to cover and did CAT scan, took me off amiodarone, put me on prednisone, and have gotten better with going to rehab. So yeah, there's no question about it. There is toxicity known in some people who've taken amiodarone, and often when you take the drug away and treat with anti-inflammatories, it goes away. And rehab, I definitely think, is going to be helpful for that. Next question, Helen, biotine, Ellen, biotine, Denise, tell him biotine, John, biotine. Thank you. If I wouldn't have thought of it by then, or if I didn't have Google, I would have gotten back to that dry mouth again. Thank you all for the assistance. I appreciate it. Next question, in the Respimat? Yes, it does. Okay, so this is back to that question before from Carol, where I asked about, what medications were in the Respimat, and she told me it was Stiolto. Okay, so now let me show you something. This here is a chart that I made, basically organized all of the respiratory medications into their different classes. And when it comes to the inhaled respiratory medications, okay, there are basically two major divisions. The two major divisions are bronchodilators, which means they open up the airways and the lungs, and inhaled corticosteroids, which are anti-inflammatory, okay? The bronchodilators are divided into two classes. A, anticholinergic, B, beta-2 agonist, C, corticosteroid. And this is a lot like when you went to a Chinese restaurant, no disrespect, Chris, in the 1970s. I don't even think you were born yet, but you picked one from column A, one from column B, and one from column C. Okay, most patients with COPD are treated with one anticholinergic, one beta-2 agonist, one corticosteroid, and there's a lot of different ways, whereas before you used to have to take each one individually. Okay, then we saw combination medications in which we saw a combination of beta-2 agonists and steroids, and you had to take your anticholinergic separately. Now we're seeing, your combination, which is basically Stiolto, which is a combination of the 2 bronchodilators, anticholinergic and beta-2 agonist, and then you have a separate steroid, which in my opinion, I've been waiting for this one for a decade, because it makes the most sense to take your 2 bronchodilators together, wait a little bit of time, 5 to 15 minutes, let them start to work, and then take your anti-inflammatory. Okay. I asked one, he doesn't want to so far. Okay, what probiotic do you recommend? As I mentioned before, VSL number 3. Do you think nebulized induced mucus will give my specialist more info than self-induced mucus? So here's the thing. Sometimes, I don't necessarily think that is so. Sometimes people can get mucus through a sputum induction that they can't get on their own, or they may get deeper mucus. But we have an airway clearance unit here run by Marian Maklis, and through using either chest physical therapy, where she's manually performing a treatment on you, or the acapella valve, or the aerobica, or the lung flute, or the quake, which I know Mark likes, I think that can be just as effective as sputum induction. Next. To be clear, my recommendation would be to have an endocrinologist next. Not necessarily. I would say I would go with a really good internal medicine doctor, maybe with a subspecialty in endocrine, or a cardiologist. The thing is that it's not always a clear-cut, specialty by specialty. You want the smartest person, the person who can, go in and look at each tree individually and come out and look at the forest, and then go back in and examine the trees individually again. You want the smartest person. I mean, to me, I want the smartest doctor, but I also want someone who's nice. I want someone who's a good people person, but that also has the knowledge and experience to, to get to the bottom of it. Mendo Bruce says, perhaps the reason they want induced sputum is because it will be collected in a sterile environment. That's possible, but I mean, sputum's not sterile, but if you have the cup and you catch it right away and you spit it into the cup and close it up right away, we can usually, usually that's good enough. Anyway, that ends the question and answer period for tonight. I hope you learned something. Again, I would like to say thank you all so much for your time and attention. I want to thank Chris for his time and attention, without whom we could not have built the Ultimate Pulmonary Webinar Series. Unless we got someone else like him with a different name, then we probably could have done it also. But there's a lot of people that are involved. I want to thank Rena Miller, who is my co-admin in the Facebook group. I want to thank all the members who, we started our Ultimate Pulmonary Wellness Facebook group of just about maybe 2 months ago. I think we're already up to almost 1,500 members. And what a super positive group of, positive, cheerful, smart, intelligent, not backbiting, not politically BS, negative, sulking, individuals. I mean, it's a really good group of people. And I also really want to thank all of the Facebook groups that I'm a member of. I don't post a lot in the other groups, but if somebody tags me, I'll always come in. But I want to thank all the other admins and all the other members of the Facebook groups that I'm a member of that allow me to post about my webinars, graciously, because, there's really no competition. There's no competition amongst us. We're all in this boat together. And as you can see, anything I have, I will give to you freely. Any information I'm willing to share. One thing I'm going to do tonight is I'm going to post again, actually the medication list that I talked about with the A's, B's, and C's is in the files of the Ultimate Pulmonary Wellness Facebook group. So I've said that name of the group enough times, you get the idea. But again, I want to thank all of you for tuning in. I want to thank the admins of all the groups. I want to thank the American Lung Association for always supporting anything that we do here. I want to thank the Pulmonary Fibrosis Foundation, who we're about to really get going with. We did a great walk, and I want to say shout out to Sylvia, who we did the walk with last Saturday, 3.7 miles in Central Park. There's a lot of people working on helping you guys with respiratory disease and cardiovascular disease right now. And I want to just say that the more we work together, the better chance we all have of having the best results. And I do want to thank, all the RTs and, in particular, Mark Mangus, who's a member of our group and really does so much teaching and sharing, and Mike Hess, and Kelly, and I know I'm forgetting people. Don't take it as disrespect. Just take it as me being tired. But without you guys, there's always something to learn. And every time we think we've got it down pat, or we think we know it all, there's always someone wiser than us and or more experienced than us that can help kind of fill in the blanks for us. And so I do appreciate you guys. And I'm going to stop rambling now. So thank you all. Have a great night. And John, I'm going to surprise you one of these days. I may come in a Yankee uniform just to make you happy, okay? But I would be surprised. I didn't know you were a Yankee fan. All right, my people, thank you so much. Have a good evening. I will see you in September, but I will be active in the Ultimate Pulmonary Wellness Facebook group, and by September 15th, my birthday, I'm just giving you time to shop. I promise, hope, pray that my book, Ultimate Pulmonary Wellness, will be done and available for you, okay? Peace! New York Mets.